Good morning, one and all. I'm Dr. Vaishnavi, and today's seminar of mine will be on an approach to chronic diarrhea. So, as pediatricians, we deal with diarrhea day in and day out of the practices every day, but then chronic diarrhea is a different entity altogether. Because of its varied etiologies and varied types of management in chronic diarrhea, this calls for a unified approach while we dealing with a child of chronic diarrhea. So, diarrhea is defined as any stool volume which is lasting for more than 10 grams per kg in a toddler or infant and more than 200 grams per kg in an older child. And since it's not practically possible to measure the stool volume every day, any change in the consistency of stool, that is a loose or a watery stool, or the number of stools which is more than 3 times per day, is considered as diarrhea. And when this diarrhea is lasting for 4 weeks or more, he label it as chronic diarrhea. Now, coming to what is a persistent diarrhea. Persistent diarrhea is something of an infectious etiology, that is diarrhea which has begun acutely but it has lasted for more than 14 days, then we call it a persistent diarrhea. Another clue in our history while we're dealing with diarrhea is that if the mother classically tells the history that the child wakes up in the middle of the night to pass stool, most often we are dealing with an organic cause of diarrhea here rather than a functional cause. So let's begin with a couple of case scenarios. Here we had a 4-year-old male child who presented it to us with fever, loose stools, and vomiting. Moderate to low grade fever, which is not associated with any chills, vigors, or rash. Complaints of loose stools for the last 20 days, which was sudden onset loose stools, large volume stools around 6 to 7 times per day, watery explosive stools, which is not blood stained or non mucoid. Initially, for the first 4 to 5 days, this was associated with vomiting. So, other than this, the child was a well thriving child with no significant past history or family history. On examination, we didn't find anything other than mild perianal erythema. Other signs of dehydration was not there. Other systemic examination was also within normal limits. So, what do you think we are dealing with here? Here we are dealing with a well thriving child with persistent diarrhea. Since the diarrhea lasted for around 20 days, so we are dealing with a well thriving child with persistent diarrhea with secondary lactose intolerance. Now, why do I call it secondary lactose intolerance? Because on history, we get the examine. On history, we have a classical clue that the stools are large volume and explosive stools. And on examination, we also found that there was perianal erythema. So these are the signs of secondary lactose intolerance. Now, coming to why is persistent diarrhea occurring? What is the reason why some of these diarrheas, which begin acutely, why do they persist for 14 days or more? So, in the pathogenesis of persistent diarrhea, it is a vicious cycle of prolonged diarrhea leading to malnutrition, malnutrition leading to malabsorption, malabsorption further exacerbating diarrhea, and then diarrhea again leading to malnutrition. So, it is a vicious cycle which is continuing in case of persistent diarrhea. There is small mucosal injury, there is villus atrophy, loss of these fresh powder enzymes, so that leads to compromised gut immunity. Leads to superadded infections like fungal infections. Because of the loss of fresh powder enzymes, we have lactose intolerance, hypoalbuminemia, and all of these will lead to again worsening osmotic diarrhea. So, our mainstay of management in persistent diarrhea will be to break this vicious cycle. Now, what is the secondary lactose intolerance? So, basically, what happens is after diarrhea, because of this impaired gut repair mechanisms, there is loss of these brush powder disaccharidases which are present in the villi. So, normally, what happens when lactose enters the small intestine is because of the presence of this lactase enzyme, lactose is broken down into glucose and galactose, which will be further absorbed in the small intestine. But in case of secondary lactose intolerance that occurs after diarrhea, there is loss of these brush powder enzymes. So when lactose enters small intestine, because of the absence of these brush powder enzymes, this lactose further enters the large intestine where it is fermented by the large intestinal bacteria. Now, this fermentation of lactose will lead to production of gas and acids, and this gas is classically what is responsible for this borborygmi or explosive stools and bloating sensation which the parents complain of, or this acid which is generated that is responsible for the acidic pH which will cause perianal erythema and excoriation. What is the management of persistent diarrhea? So, management of any persistent diarrhea is a three-tiered approach where you have to correct the dehydration and electrolytes. Like in any case of acute diarrhea, go for the symptomatic management, assess for signs of dehydration, look for any electrolyte imbalance. If any of these is present, manage it accordingly. So, once we are done with acutely stabilizing the child, look for the causes of infection, look for the clues of infection, and if any found, treat the infection accordingly. And last but not the least is the nutritional therapy, which is particularly particularly important in the management of persistent diarrhea. Now, what is this nutritional therapy which is important in diarrhea is, so when a child with diarrhea comes to us, keeping the child NPO is not the solution to stop diarrhea. Keeping the child NPO is further going to worsen the nutritional status and the malabsorption status, further worsen diarrhea. So dietary management is particularly important in these cases, and it has to be customized according to the child. You have to supplement multivitamins and minerals at twice the really recommended dose, and also start dietary management. You start initially with a lower calories, around 100 kilocalories per kg per day, which will then be gradually hiked to 150 kilocalories per kg per day by 1 to 2 weeks. Apart from this, as we have already seen, persistent diarrhea is a state where there is lactose intolerance. Varying degrees of carbohydrate exclusion is necessary to overcome this carbohydrate malabsorption. Now, how do we do this carbohydrate exclusion? So these are the three diets which are described for persistent diarrhea. This is a table from Guy which has described three diets classically. The first diet is that of a reduced lactose. So when a child is having lactose intolerance, first try to reduce the amount of lactose which you are giving in the diet. Now suppose the child is not improving on this reduced lactose diet, go for diet B, which is a lactose-free diet. So lactose-free diet is where you entirely eliminate lactose altogether from the diet. But even after shifting the child onto a lactose free diet, if it is still persistent, then change it to a monosaccharide based diet. So we already know that the disaccharidase is enzyme certification, so change it to an entirely monosaccharide based diet. So this is a table which shows how you make these three diets, which is already given in guide. Now, what are the indications to change the diet in a persistent diarrhea? So, suppose we started the child on the type A diet and the child has not responded to us in 2 to 3 days. In 2 to 3 days, the child is persistently is still having some amount of diarrhea. Is that an indication to change to type B? No. So the guidelines recommend that the indications to change from the initial diet is that once you've started the child on a diet, despite starting on a diet, if the child is still having a marked increase in the stool frequency, or any time after starting the diet, there are signs of dehydration, you will have to change the diet. But if the child is not having any signs of dehydration or increased frequency of stool, but still the child has failed to gain weight by day 7 of starting the diet, that calls for an indication that you have to upgrade the diet. Now, coming to chronic diarrhea, as you can see here, this is the table from Guy which has classified the etiologies of this chronic diarrhea as per the age. And this list is huge. So, since this list is huge, this calls for a need for a unified approach or a targeted approach. So, once we have a targeted approach, we can classify these diarrheas and then come on to etiology. So for this, any child who comes to you with a chronic diarrhea, it is necessary to answer this following 6 questions. So once a child comes to you with diarrhea, answering these 6 questions will help me in localizing the etiology or characterizing the type of diarrhea. And once you have characterized the diarrhea, it will be easier onto a further etiologic management. So the first question is, first find out or answer whether it is an acute diarrhea or a persistent diarrhea or a chronic diarrhea. Next, is it a small bowel diarrhea or a large bowel diarrhea? Now, why is it important to know if it is a small bowel diarrhea or a large bowel diarrhea? Because the small bowel diarrheas are mostly of malabsorptive etiology, while the large bowel diarrheas are mostly of inflammatory etiology. Now, the next question as to whether it is a secretory diarrhea or an osmotic diarrhea. Now, how do we know if it is a secretory or osmotic diarrhea? So we'll see about that in the upcoming slides, whether it is an inflammatory diarrhea or a non-inflammatory diarrhea. And look for any signs of malabsorption. Are there any signs pointing towards your fat malabsorption or carbohydrate malabsorption or protein loss or micronutrient deficiency? And last but not the least, look for specific clues or associated symptoms in your history and detailed examination. So as we already saw, a persistent diarrhea is something which has started acutely and lasted for more than 14 days. A chronic diarrhea is something which has lasted for more than 4 weeks. Now, the second question as to whether it is a small bowel or a large bowel diarrhea, it helps us to know whether it is of a malabsorptive etiology or an inflammatory etiology. Now, a small bowel diarrhea, the stool is characteristically large volume, pale, offensive stools which do not contain any blood or mucus. But large bowel diarrheas are of moderate quantity diarrheas, which are usually associated with blood and mucus in the stools. Large bowel diarrhea is also associated with your rectal symptoms like urgency and tenesmus. Pain abdomen and large bowel diarrhea is a hypogastric pain abdomen which is characteristically reduced after passing the stool, while small bowel diarrhea can also have pain abdomen that is more or less classically periumbilical, which does not reduce after passing the stool. Apart from that, in a small bowel diarrhea, like we said, look for signs of malabsorption. You can get greasy stools, carbohydrate malabsorption signs, protein malabsorption signs, and nutrient deficiency. The next question as to whether it is an osmotic diarrhea or a secretory diarrhea. Now, what is an osmotic or a secretory diarrhea? An osmotic diarrhea is something which is occurring because of the non-absorbed nutrients which is present in the intestinal lumen. While secretory diarrhea is something which is because of an active water and electrolyte secretion into the intestinal lumen. Now, how do we differentiate between the secretory and osmotic diarrhea is by a simple test, that is keep the child NPO or reduce the oral feeding of the child. So once you keep the child NPO, if your stool volume has reduced, that means it was because of a osmotic component. But even despite keeping your child orally NPO, the diarrhea amount persistently is still continuing. That means there is active secretion which is still going on, and that is a secretory diarrhea. Now, this secretory diarrhea might be because of the inhibition of the NaCl absorption, or it might be because of increase in electrogenic chloride secretion. But this osmotic diarrhea is whenever there is an impaired absorption of these nutrients. It might be because of your nutrition, intestinal damage, or because of the reduced absorptive surfaces like you see in celiac disease, or it might be because of the defective digestive enzymes like we saw in lactase deficiency. This is again a pictorial representation of an osmotic and secretory diarrhea. Another way to find out whether it is an osmotic or secretory diarrhea is what we call as a stool osmolar gap. Now, what is the stool osmolar gap? A stool osmolar gap is calculated as 290 minus 2 times stool sodium and potassium. Now, if the stool osmolar gap is high, that if it is more than 100, then that means it is an osmotic diarrhea. If it is less than 50 is because of active secretion of all of your electrolytes. So if it is less than 60, then that is a secretory diarrhea, and 50 to 100 falls in an inconclusive range. Now, we also had to look for the signs of malabsorption, which was our fifth question that had to be answered. So in this, look for the signs of fat malabsorption, carbohydrate malabsorption, protein loss, or micronutrient deficiency. Now, what are these signs respectively? Fat malabsorption classically presents with pale, bulky, foul-smelling stools. Carbohydrate malabsorption will present with abdominal pain and flatulence. Borborygmi, that was his explosive stools with perineal edema. Protein loss, which will present with non-pitting edema, abdominal distension, micronutrient deficiencies like anemia, in case of B12 folate deficiency, angular stomatitis, night blindness, etc. The last important question that we had to answer was look for associated symptoms, look for specific clues which will point towards an etiologic diagnosis. Like, say, a well thriving child has presented to you, no other symptoms, just the child is having diarrhea. We might be dealing with a functional or toddler's diarrhea. If there's abdominal distension, anemia, and weakness, might be dealing with celiac disease. If there is severe abdominal pain, bloody diarrhea, oral ulceration, we are dealing with something which is inflammatory, that is IBD. Vomiting and rash might point towards eosinophilic enteritis. If the child is complaining of alternate constipation and diarrhea, we might be dealing with IBS or Hirschsprung. If the child has severe napkin dermatitis, which is resistant to most treatment, it might be acrodermatitis enteropathica. So the non-GI symptoms that we have, the silent hints that we have is some child who's coming to you with recurrent respiratory tract infection, look for CF. If the child comes to you with headache and mood changes, IBS. If the child comes with generalized eczema, atopic dermatitis, maybe CMPA or eosinophilic enteritis. Child coming to you with generalized lymphadenopathy, recurrent fever, weight loss, or ear discharge, respiratory infections, we might be dealing with immunodeficiency. On examination, again, look for the other signs which will point towards diagnosis like after stomatitis, pointing towards IBD or celiac disease, stomatitis, glossitis, or angular cheilitis, that is telling you the signs of malabsorption, diaper or a perineal rash, which might be because of both. It can be because of acidic stools and carbohydrate malabsorption, or it could be because of zinc deficiency as an enteropathica. Look for cutaneous rashes like your dermatitis herpetiformis in celiac disease, atopic dermatitis in CMP. A perianal fistula might be suggestive of Crohn's disease. And the other examination findings like abdominal distension. This abdominal distension might be because of your carbohydrate malabsorption secondary to gas, or it might be because of protein malabsorption like in PLE. Look for other signs like koilonychia, which is suggestive of iron deficiency. Now, this is a diagrammatic representation of my approach to chronic diarrhea. So, what we do here is when you have a child with the diarrhea lasting for more than 4 weeks, on history and clinical examination, look for danger signs. Assess the general dehydration status and the electrolyte status of the child. So, anytime the child is having red flags and you know the particular cause, treat that. If the child is unwell or dehydrated, manage the child symptomatically. After this, a simple test like a couple of stool examination and a couple of blood tests which will help me characterize the type of diarrhea and characterize it into whether it's a watery diarrhea, whether it's an inflammatory diarrhea or a fatty diarrhea. So, in an Indian setting or in most of our settings, the most common causes of chronic diarrhea is always an infectious cause and celiac disease. So, any child who presents to you with a chronic diarrhea, rule out celiac and infection before going on to your further workup. So after this, we have done a couple of stool examination and a blood examination. If there are no red flags, the stool examination is normal, blood examination is normal. We are likely dealing with what is called as a functional diarrhea. But again, on your stool microscopic examination, if there is stool microscopy is normal and fecal calprotectin is less than 50 microgram, we are dealing with a watery diarrhea. However, if the microscopy is positive and fecal calprotectin is more than 50 micrograms, we might be dealing with an inflammatory diarrhea. But if your stool microscopy is normal and however you do find fat globules of stool examination, we are dealing with what is called as a fatty diarrhea. So these are three types of diarrhea: watery diarrhea, inflammatory diarrhea, and a fatty diarrhea. Now let's begin with an approach to watery diarrhea. Let's begin with another case scenario. So here we had a 2-month-old infant with uneventful antenatal and natal history who presented with smooth perinatal transition, but then he also had complaints of poor weight gain since birth and increased frequency of stools for the last 6 weeks. The stools were described by the mother as profuse, watery, explosive stools of around 10 to 15 times per day, not containing any blood or mucus. There was no abdominal distension. However, there was mild perianal redness was seen. Otherwise, the child was exclusively breastfed and the diarrhea was reduced by keeping the child NPO. Family history showed that it was a second degree consanguineous marriage with a history of sibling death because of similar complaints of diarrhea. Now, based on this history, what are we dealing with? So, to answer my 6 questions that I had described, whether it's an acute or chronic diarrhea, it is a chronic diarrhea. This is a small bowel diarrhea, osmotic or secretory, because this diarrhea decreased on keeping NPO, it is an osmotic diarrhea. Whether it's inflammatory or non-inflammatory, non-inflammatory. There was no signs of any blood or mucus in the stools. There was no abdominal pain, which was classically described. Any signs of malabsorption? Yes, we do have signs of carbohydrate malabsorption. There was perianal erythema was there. There was also bloating sensation was there. Associated features. In associated features, there was history of consanguinity, infantile onset, failure to thrive, and sibling death. To summarize, we have an infantile onset, chronic small bowel diarrhea, watery osmotic, which is non-inflammatory, associated with features of carbohydrate malabsorption, sibling death, and failure to thrive. So the first possibility that we considered here was of congenital osmotic diarrheal diseases. Now, an approach to chronic diarrhea. So, whenever you have a child with chronic diarrhea, you have to differentiate whether it is an osmotic diarrhea or a secretory diarrhea. So, as we already saw, when you get the child NPO, if it resolved with fasting or your stool osmotic gap is more than 100 or your stool reducing substance are positive, then we are dealing with an osmotic diarrhea. And so now that we know we're dealing with an osmotic diarrhea, look at the age of presentation. Any child which is presenting in infancy or a newborn period, rule out the major surgical abnormalities first. After you rule out the surgical causes, go ahead with an endoscopy, biopsy, or quantification to rule out what is known as the congenital osmotic diarrhea. Now, if the same osmotic diarrhea presents to you in an older child, it might be because of bacterial overgrowth. So, to test for this bacterial overgrowth, go ahead with the breath hydrogen testing. So, if your breath hydrogen testing is positive, it might be because of either your carbohydrate intolerance or it might be because of bacterial overgrowth. However, if it is negative, we might still be dealing with enteropathies for which we need to go ahead with endoscopy and biopsy. Now, the same child with watery diarrhea, but you have clues that it is a secretory diarrhea. It didn't improve on keeping fasting or your stool osmotic gap was still less than 50, then you're dealing with a secretory diarrhea. So in a secretory diarrhea, again look at the age of onset. It is if it is presenting in newborn or infancy, rule out the surgical causes first. And apart from this, you can still be dealing with what is known as the congenital secretory diarrheas or your enteropathies. So to look for your enteropathies, you have to go ahead with an endoscopy, biopsy, and light microscopy and electron microscopy. We might be dealing with something like microvillus inclusion disease or tufting enteropathies. If the same secretory diarrhea presents to you in an older child, always and always look for neuroendocrine tumors. Test for VIPs, gastrin, calcitonin. We might be dealing with neuroendocrine tumors. Just a brief note on a congenital diarrheal diseases. A congenital diarrheal disease is because of a permanent defect in the structure or function of an enterocyte, which is leading to progressively and potentially irreversible intestinal failure. So, this congenital diarrheal diseases can be of any of these four categories. It might be because of a defect of digestion, absorption, or transport, or it might be a defect of enterocyte as per se, or it might be a defect of enteroendocrine cells, or it might be a defect in the modulation and intestinal immune response. So these diseases are relatively very rare in a general population. Now, suppose you have a child where you're suspecting a watery diarrhea. In the watery diarrhea, you know that there are signs of carbohydrate malabsorption like explosive watery diarrhea. Keep the child NPO for 24 hours. So now that you've eliminated carbohydrate, if there is an improvement, we're sort of sure that we're dealing with carbohydrate malabsorption. Now start the child on ORS. So when you started the child on ORS, if there is no recurrence of diarrhea, ORS is containing glucose. So the child, if is not recurring on an ORS based diet, that means the child is tolerating glucose. So there is deficiency of other carbohydrates, that is congenital lactase deficiency or your sucrose isomaltase deficiency. But once you started the child on ORS, if the child has recurrence of diarrhea, that means the child is also intolerant to glucose. So what do we do here is give a trial of fructose-based ORS diet trial. So an ORS which is based on fructose, if you give a trial of that and the child's diarrhea stops, that means you have eliminated glucose and the diarrhea has stopped. It is a case of glucose galactose malabsorption. However, if you don't find any signs of carbohydrate malabsorption and it's still a watery diarrhea, you're suspecting congenital onset, go ahead with endoscopy and biopsy. So in endoscopy and biopsy, if you find villus atrophy, we might be dealing with the brush-borne defects like NVID. If there is no villus atrophy, we might be dealing with something like the channel diarrhea, that is a congenital sodium or chloride diarrhea. So in our case, record. So we switched on to a fructose-based ORS, after which diarrhea significantly reduced and the child started gaining weight adequately. So here we are dealing with what is known as a glucose galactose malabsorption defect. So coming to our next category of diarrheas, which we saw was an inflammatory diarrhea. Here we have a case of an 18-month-old boy who was symptomatic for the last 6 months. So what are the symptoms? He complained of abdominal distension and bloating, which increased after eating meals. Increased frequency of stools around 5 to 6 times per day, non-blood containing, non-mucoid, sometimes nocturnal, large volume stools which were explosive. The child also was noticed to have not been gaining weight and height adequately. Otherwise, there was no significant past or family history. There was no history of any recurrent admissions or infections. There was no history of oral ulcers or joint pain. There was no history of allergy or atopy. And there was no significant family history otherwise. On examination, we found that the child had failure to thrive. The child had weight and height in less than 5th centile. There was pallor present. There was abdominal distension with mild perineal redness. So, to answer back our 6 questions that we were dealing with, is it an acute or chronic diarrhea? It is a chronic diarrhea. Is it small bowel or large bowel? It is small bowel. There were no signs suggestive of inflammatory or large bowel diarrhea types. Is it osmotic or secretory? We can't comment on that here because we don't know if the diarrhea stopped after keeping the child NPO. Definitely, it is non-inflammatory. Among the signs of malabsorption, we did find signs of carbohydrate malabsorption. Like we saw, there was redness and there was bloating. And also there was explosive stools. Associated features was that the child had anemia, the child had short stature, child had failure to thrive, and signs of vitamin B deficiency. So here we are dealing with a chronic diarrhea of small intestinal type, non-inflammatory, associated with carbohydrate intolerance with abdominal distension, failure to thrive, and anemia. So, what are the possibilities that we are dealing with? First possibility is again celiac disease, CMPA, or lower down you can give the possibility of infection like giardiasis. Now, coming to the inflammatory or immunologic causes of diarrhea, we have causes like celiac disease, which is a genetically predetermined permanent intolerance to gluten. Food allergy, as seen in case of CMPS, other inflammatory etiologies like your IBD, Crohn's, and ulcerative colitis. You can also be dealing with your autoimmune enteropathies, which are mostly IgA mediated, or it could be an IPEX syndrome. Now, to begin with the celiac disease, just a brief note on the recent recommendations on the guidelines for diagnosis of celiac disease. The guidelines recommend that you have to go ahead with a esophageal gastroduodenoscopy with multiple duodenal biopsies. Now, the question as to why do we need multiple duodenal biopsy? Why is not one sufficient? This is because of the patchy involvement of the disease. So go ahead with multiple duodenal biopsies, one or two from the bulb and four from the distal duodenum for confirmation of diagnosis in both children and adults where you have a suspicion of celiac disease. However, they do suggest that a combination of high level of TTG IgA, that is more than 10 times the upper limit of normal, with a positive endomysial antibody in the second blood sample is as reliable for testing celiac disease as biopsy, but this is only in children. So these are the guidelines which is recommended by the American College of Gastroenterology 2023 guidelines. So this is a classical table that they have described. So in this table, it's divided into two groups, the ones who are already on a gluten-free diet and the ones who are on a normal diet. So what do you do when a child is on a normal diet? Child is on a normal diet, first go ahead with your serologic testing. This American College of Gastroenterology recommends concurrent testing of both TTG and total IgA. Now, if you have your TTG positive, if it is an adult, definitely go ahead with the biopsy. On the biopsy, if you find March 1 to 3, it is a celiac disease. If biopsy is normal, label him as a potential celiac. But in children, we have two options. You can go for a non-biopsy approach or a biopsy approach. So, non-biopsy approach is something when the parents do not want a biopsy and the child has classical signs and symptoms of celiac disease with anti-TTG more than 10 times the upper limit of normal, go ahead with an endomysial antibody. So, if that is also positive, this is sufficient to label the child as celiac and start him on GFT. But however, in case anti-TTG is positive but not as high as 10 times upper limit, then you will definitely have to go ahead with biopsy to confirm the diagnosis of celiac disease. Now, what do we do in case your total IgA is less? What if the child is IgA deficient? So, if the child is IgA deficient, then you have to go ahead to test for IgG antibodies. Now, in these IgG antibodies testing, you can either test for TTG or DGP. DGP is nothing but deamidated gliadin peptides. Now, if these two are positive, you still have to go ahead with biopsy to prove that it is a celiac disease. Now, what if your anti-TTG IgA is negative? The child is total IgA is proper, the child is not IgA deficient, but your TTG IgA is negative. Celiac is unlikely, but then if you still have a high suspicion of celiac, go ahead with the biopsy. In the biopsy, if you find any signs of atrophy, you can label the child as seronegative celiac disease. But also keep in mind that this atrophy that you find on biopsy can be because of other causes as well. It can be because of other causes like CVID, tropical sprue, or autoimmune enteropathy could still be considered when there is just biopsy with atrophy. Now, what if the child is already on a gluten-free diet? What do we do? Is there any rule of serologic testing? If there is already on a gluten-free diet, the first thing that you have to do is go ahead with HLA haplotype testing. So you have to look for HLA DQ2 or DQ8. So if this haplotype is negative, definitely the child is not having celiac disease. But if the haplotype is positive, you still have to confirm that it is still celiac disease. So go ahead with a gluten challenge. So you give 3 grams gluten daily for 2 weeks. At the end of 2 weeks, if the child is poorly tolerated, consider serology. But the child has tolerated the gluten very well, then give an additional trial for up to 6 weeks. So now we have given 2 weeks trial and 6 weeks trial. That is at the end of 8 weeks, repeat serology at the end of the challenge. And again, after stopping your gluten challenge, 2 to 4 weeks after that, again repeat a serology. If your TTG here is positive, still you have to go ahead with confirming it with duodenal biopsy. Now, this is what is a March grading. March grading is that there are three stages: stage 1, stage 2, and stage 3. Stage 1 is infiltrative, where there's increased frequency of intraepithelial lymphocytes, that is more than 25 per 100. In hyperplastic, there is crypt hyperplasia. The last stage is an atrophic stage, that is where there is villus atrophy. Now, to begin with the inflammatory or bloody diarrhea, whenever the child comes to you with blood and mucus in the stool, you have to think of inflammatory etiologies. First thing, rule out infection. After that, look at the age of the child. If it is an infantile onset or your newborn onset, rule out NAC, and also you can give a trial of what is known as maternal diarrhea exclusion or start the child on elemental formula. So if this child improves on this diet, then we might be dealing with a CMPA. But if the child does not improve on maternal diarrhea exclusion, we have to go ahead with a biopsy or endoscopy to rule out other causes like your IBD, PID, or autoimmune enteropathy. If the same inflammatory diarrhea comes to you in an older child, then you have to rule out IBD and autoimmune enteropathy altogether. So in our case, a stool microscopy and occult blood was negative, fecal elastase was negative, anti-TTG was 220, which was more than 10 times the higher limit of normal, and the parents wanted a no biopsy approach, so we went ahead with an EMA antibodies, which was positive. So we labeled the child as a celiac disease and started the child on gluten-free diet. So now we have discussed the two categories of diarrhea, that is watery and inflammatory. The last one was a fatty diarrhea. Here we have a 2-year-old child who is symptomatic for the last 1 year. That is, he had complaints of loose stools, that is around 8 to 10 times per day, foul smelling, oily, bulky stools which floats on a toilet pan, non blood stained or non mucoid. There was also a history of recurrent respiratory infections, which was requiring hospital admissions and IV antibiotics. There was also a history of inadequate weight gain in the child. Otherwise, the child had uneventful antenatal and birth history. During birth history, it was also important to know that there was history of delayed passage of meconium. There was no significant. In the family history, we found that the child had an elder sibling who died in view of recurrent respiratory infections. On examination, there was severe wasting and stunting. There was mild pallor, which was seen, but other systemic examination was within normal limits. Now, again, going back to my 6 questions. Is it an acute or chronic diarrhea? It is a chronic diarrhea. Is it small or large bowel? Small bowel diarrhea. There are no signs suggestive of inflammation or large bowel etiology. Osmotic or secretory? Can't comment upon entirely here. Inflammatory or non-inflammatory? Definitely non-inflammatory. Any signs of malabsorption? There are signs of fat malabsorption. There is bulky, offensive, pale, greasy stools which was sticking onto the toilet pan. Any associated features? There was history of sibling death, failure to thrive, and recurrent respiratory infection. So here we are dealing with a chronic diarrhea, small intestinal type, non-inflammatory, with fat malabsorption, with sibling death, associated with failure to thrive, recurrent respiratory infections, and anemia. So what are the possibilities? Yes, the first possibility that we kept here was cystic fibrosis, and the other possibility lower down was Schwann-Diamond syndrome. Now, coming to the fatty diarrhea could be because of either it could be because of malabsorption or maldigestion. Now, what is the difference between a malabsorption or maldigestion? So malabsorption is because of impaired absorption of all of these fats in the from the intestine. Maldigestion is where there is impaired enzyme deficiency. So whether it is your digestive enzymes, that is your pancreatic insufficiency, or it is because of your inadequate bile acid pool. So if it is because of the digestive enzyme deficiency, then it is maldigestion, like exuberant pancreatic insufficiency in cystic fibrosis, or your Schwann-Diamond syndrome, or inadequate bile acid pool, which is the cause of diarrhea in cholestatic disorders. Malabsorption is where digestive enzymes are normal, but your intestinal surface, which is there for absorbing all of these nutrients, that is defective. Like in case of your celiac disease or Crohn's disease, or it might also be because of something is wrong with your lymphatic channels, which is there. That is defect in the lipid transport and metabolism, which can be seen in your lymphangiectasias or chylomicron retention disease. So any child with fatty diarrhea comes to you, go for a stool microscopy. On your stool microscopy, if you're finding fat globules, go ahead and test for stool elastase and LFTs. Now, elastase will tell you about your pancreatic status. LFTs is going to tell you about your liver status. So if there is abnormal elastase but normal LFT, you know you're dealing with pancreatic insufficiency, which can be because of cystic fibrosis or your Schwann-Diamond syndrome. Or you can also be dealing with chronic pancreatitis. But your elastase is normal and your LFTs are deranged in the cholestatic picture, go ahead and evaluate the child for cholestatic liver diseases. Now, if the stool microscopy does not have any fat globules, then you have to rule out malabsorptions. That is, you have to rule out the mucosal diseases. For these, go ahead with gastroscopy and biopsies. On imaging the small bowel, you might find You on imaging the small bowel, you might find the clues of mucosal disease. You can go ahead with lymphangiography to look for lymphangiectasias. So here we have a last scenario where we had a 3-year-old child who was a well-thriving child who is very fond of soft drinks and fruit juices for that matter. She presented to us with, she's been symptomatic for the last 8 months. She presented to us with loose stools around 5 to 6 times per day, semi-solid stools, which occurred mostly immediately after eating food. Sometimes it contained undigested food particles as well. Otherwise, there was no blood or mucus, there was non-explosive, not nocturnal, and there was no steatorrhea. There was no abdominal distension, vomiting, fever, or poor weight gain. The child had normal appetite. Otherwise, basically, the child was a well thriving child. Height and weight were within normal limits. There was no other examination findings. There were no other danger signs. So, to summarize, here we are dealing with chronic diarrhea with normal anthropometry, normal appetite, and no danger signs. So, what are we dealing with here? Yes, here we are dealing with what is known as the functional diarrhea or the toddler's diarrhea. So, this functional diarrhea was previously called as the toddler's diarrhea or chronic non-specific diarrhea. Now, the recent Rome 4 diagnostic criteria it says that to label it as a functional diarrhea, the child must have four of the following features, that is, daily painless recurrent passage of at least 4 or more stools, with symptoms lasting for more than 4 weeks in a child between 6 to 60 months of age with no features of failure to thrive. If the calorie intake is adequate, there is no features of failure to thrive, then we are dealing with functional diarrhea. Now, how do we manage functional diarrhea? How do you convince the mother that it is a functional diarrhea in the child? And how are we going to go about with this management? So, we'll see that in the further management slides. So, management of chronic diarrhea, that is the treatment of chronic diarrhea, is a multidisciplinary approach. So there are different spears which you have to manage all together. Go for a general supportive measures. Look for any signs of dehydration. Always assess for signs of dehydration. Replace fluids and electrolytes if necessary. Nutritional rehabilitation, as we saw in persistent diarrhea, was particularly important. It is important in chronic diarrhea as well. There are various elimination diets that you can try in particular etiologies. And last but not the least, treat the cause of diarrhea. Now, coming to your specific nutritional rehabilitation, you have to know that in a child with chronic diarrhea, there is somebody who's having diarrhea for more than 4 weeks, the child will already be in a state of malnutrition. So, malnutrition will still be there. So, you have to be particularly careful while you're starting the child on diet because you have to avoid what is known as a refeeding syndrome. So, as you all know, refeeding syndrome, some child has come, you're starting the child on a diet, we want to avoid what is a refeeding syndrome. So, the same thing here in chronic diarrhea, you should carefully start the child with lower calorie feeds and then hike up the feeds eventually slowly. Micronutrient and vitamin supplementation, twice recommended RDA, as we've already seen. Last is nothing but you have to treat the underlying cause of diarrhea. Like, say, if you found that the diarrhea is because of CMPA, treatment is just simple. You have to change the child to an extensively hydrolyzed 100% bovine casein infant formula, or exclude dairy from the maternal and from the fetal and from the child diet. If it is a celiac disease, start the child with gluten-free diet. In case of lactose intolerance, eliminate lactose from the diet. If it is something like autoimmune enteropathy, then the child might need immunosuppression as well. On coming to functional diarrhea management, there is what is called as the 4F principle. Reduce fructose and fluids, increase fat and fiber. 4F is reduce fructose and fluids and increase fat and fiber in the child's diet. So, to end the session, the take home points is any child with chronic diarrhea, your history, physical examination plays a pivotal role. History, physical examination, and basic stool investigation will help me characterize the type of diarrhea. It will help me put the diarrhea in one of the three boxes, whether it is watery, inflammatory, or fatty diarrhea. And in any of the cases of chronic diarrhea, the first two common causes of diarrhea is always infection and celiac disease. So rule out infection and celiac disease in any age group or any presentation because celiac, as we already know, has a varied presentation. So in a chronic diarrhea with absence of any red flags on history and examination, investigations are normal, child is well thriving, you're just likely to be dealing with a functional or toddler's diarrhea or irritable bowel syndrome, and that does not call for any further invasive testing or monitoring. Thank you.